Good morning, everyone. Today we'll be presenting a musculoskeletal case presentation on post-operative ACL reconstruction. In this presentation, we'll briefly discuss the anatomy and function of the ACL, the mechanism and severity of injury, medical management, and most importantly, the post-operative consideration and rehabilitation aspect relevant to physiotherapy. I am Muhammad FATHI, and joined with me is Jing and CHEONG. Let us begin. To understand the why behind reconstruction, we first look at the anterior cruciate ligament or ACL. It is a robust intra-articular ligament extending from the anterior tibial plateau to the lateral femoral condyle. Its primary job is mechanical. It prevents the tibia from sliding forward on the femur. Beyond that, it acts as a secondary stabilizer for rotational movement and prevents hyperextension. In the clinical context, the ACL is what allows dynamic cutting and pivoting. When this ligament is compromised, the patient loses the essential stability, which is exactly why surgical intervention becomes necessary for active individuals. Moving into the pathophysiology, an ACL injury occurs when the ligament is overstretched or torn, typically through sudden deceleration, pivoting with a fixed foot, or hyperextension. When this happens, the mechanical stability we discussed is lost, leading to increased anterior tibial translation. This isn't just a one-time event. It alters the entire kinematics of the knee, placing excessive stress on the menisci and articular cartilage. If left untreated, this chronic instability often leads to secondary meniscal injuries and significantly increase the risk of early onset osteoarthritis. Most ACL injuries are non-contact, occurring during sudden changes in direction or incorrect landings. However, contact injuries involving direct blows that cause valgus stress or hyperextension are also significant. We see this most often in young physically active individuals, particularly in high-impact sports like football, basketball, and skiing. It's also important to note the gender disparity. Females are 2 to 8 times more likely to suffer an ACL injury than males. Due to these high rates, it remains one of the most frequently reconstructed knee ligaments in orthopedic practice. Clinical management of an ACL injury is heavily dictated by its severity, which we classify into 4 grades. Grade 0 represents a healthy, intact ligament. Grade 1 involves microscopic tearing where stability is maintained and conservative physiotherapy is often sufficient. However, as we move to Grade 2, we see partial disruption of the fibers, leading to increased tibial translation and intermittent instability during pivoting. Finally, Grade 3 is a complete rupture. This grade presents with significant knee instability, frequent giving away, and often concurrent meniscal damage. For active individuals in this category, surgical reconstruction is a standard clinical pathway to restore function. Building on our understanding of risk incidents, we have to look at the specific factors that predispose individuals to ACL tears. Anatomically, a narrow intercondylar notch or an increased Q angle, which is often more pronounced in females, can create mechanical disadvantages. Hormonally, research suggests estrogen may influence ligament laxity. From a performance standpoint, we look at neuromuscular and biomechanical factors such as quadricep dominance or excessive knee valgus during landing. Finally, extrinsic factors like improper footwear or unstable playing surfaces play a critical role in the environment of the injury. For a definitive diagnosis, doctors utilize a combination of clinical exams and imaging. Tests like the Lachman and anterior drawer are essential to physically assess tibial translation, while X-rays rule out fractures. MRI remains the gold standard to confirm the grade of the tear and check for associated meniscus damage. In terms of management, we categorize patients into 2 pathways. Conservative management, involving activity modification and physiotherapy, is indicated for partial tears or low-demand patients. However, for young active individuals with complete ruptures and chronic instability, surgical reconstruction using an autograft or allograft is the primary recommendation to restore long-term function. When conservative management isn't enough, we move to ACL reconstruction. It's important to note that the damaged ligament isn't actually repaired, it's replaced with a graft to restore stability and prevent secondary meniscus damage. We generally choose between 2 graft types. Autografts, typically from the patient's own hamstring or patella tendon, offer better incorporation and no risk of disease transmission, though they do cause donor side pain. Alternatively, allografts taken from a donor provide a shorter surgical time and no donor side morbidity, but they carry a slightly higher failure rate in younger, high-activity patients. The choice ultimately depends on the patient's age and functional goals. Deciding on surgery involves weighing several clinical factors. We primarily indicate reconstruction for patients experiencing symptomatic instability, such as recurrent giving way episodes, or for young active individuals in high-demand sports where knee stability is essential. It is also necessary when there are associated injuries like meniscal tears that require stabilization. On the other hand, surgery is contraindicated for patients with low activity levels who maintain functional stability without symptoms. We also avoid it in cases of severe osteoarthritis where surgery may worsen symptoms, or when poor patient compliance with intensive post-operative rehabilitation would likely lead to failed outcome. To wrap up the surgical perspective, we have to address the potential hurdles in the recovery journey, the complications and precautions. Common post-operative issues include pain and swelling, which can unfortunately limit early range of motion. We also watch closely for knee stiffness, particularly a loss of extension and quadricep weakness due to disuse. While rare, infection and graft failure remain the most serious risks, often tied to premature return to sport. To mitigate this, our precautions are strict. We must avoid excessive early loading to protect the graft during its healing phase. Success depends entirely on a proper exercise progression and strict adherence to the rehabilitation protocol.
According to the literature reviewed by Rukoska Kogut et al., contemporary physiotherapy protocols after ACL reconstruction have shifted away from fixed timelines. Instead, progression to subsequent phases should be based on patient performance and readiness. These modern standards prioritize early recovery of range of motion, early increases in weight bearing on the operated limb, and the shortening or complete exclusion of immobilization and knee orthosis to improve functional outcomes. In managing post-operative recovery, the use of continuous cryotherapy has been shown to be more effective than traditional ice packs. As concluded in the randomized controlled trial by Liv to Can Tran et al., continuous cryotherapy is significantly more effective at reducing post-operative pain and knee swelling. Furthermore, it enhances knee mobility and overall patient satisfaction, underscoring its crucial role as an evidence-based intervention to promote faster recovery. Addressing the timing of weight bearing, the study by Mardani Kiwi et al. Concludes that immediate full weight bearing post surgery is not harmful. The evidence shows that it does not negatively affect short term clinical or functional outcomes compared to delay or partial weight bearing. Additionally, the research indicates that the routine use of a brace is not necessary, as patients can bear full weight as soon as they can tolerate it without adverse effects on their surgical results. Now I'm going to briefly explain the Melbourne protocol of post-ACL reconstruction in physiotherapy. We start with the pre-op phase, the injury recovery phase. The goal here is to eliminate swelling and regain 90% of strength in quads and hamstrings before surgery even begins. Once the reconstruction is done, we enter phase 1, recovery from surgery. Our main objective here is getting the knee into full extension and getting the quadriceps firing again. We measure success by ensuring a passive knee extension of 0 degree and at least 125 degree of flexion. Once the swelling is controlled and the quads are active, we move into functional training. In phase 2, the focus shifts to strength and neuromuscular control. We are looking for the patient to regain single leg balance and perform a single leg squat with good alignment. To progress, they must hit a 1.5 times body weight goal on the leg press and squat. From there, we move to phase 3, running and agility. This phase is dominated by hopping performance. We use the triple hop and side hop test to ensure the injured side is at least 95% as strong as the healthy side. We also increase the strength requirement to 1.8 times body weight. After meeting these physical markers, we prepare the athlete for actual demands of competition. Phase 4 is the return to sport. Here we progress from restricted to unrestricted play. A key outcome measure is the Melbourne Return to Sport score, where we look for a 95 or higher. We also use the SLRSI to make sure the athlete is mentally confident and ready for contact. Finally, we have Phase 5, prevention of re-injury. The goal is to maintain long-term health. We implement injury prevention programs like the 11 plus or PEP. For this to be successful, they must be performed at least once a week or at least 6 weeks. This completes the protocol, moving the patient from initial injury back to a long-term athletic health.
Now I'm going to present our case study. The first visit is in ward POD1 on 3rd December 2025. Our patient name is Tan Lei Li. She is a 57 years old Chinese female. She is also a housewife. She admitted in hospital on the 1st December and did her surgery on the next day. She referred to physio on 3rd December 2025. Her diagnosis is left knee ACL complete tear, lateral meniscus tear, and patella maltracking. So doctor managed to do operation, which is arthroscopy left knee ACL, bone patella tendon bone allograft, lateral meniscectomy, and lateral patella release. The medicines are Celebrex, Tramadol, and Zynet. Patient complained pain at left knee, especially when moving leg, which makes it hard for her to move her left leg. She felt throbbing pain and sharp pain during leg movement. The aggravating factor is full knee extension and knee flexion. The pain score is 6 out of 10. The relieving factor is resting and when taking painkiller, which the pain score will be 2 out of 10. For the current history, patient experienced knee pain after twisting and hitting her knee during a turbulence on a flight to Ireland. She went to Ireland Hospital after deplaning, where an MRI was performed, but she refused to do surgery in Ireland. So she was managed conservatively with analgesics and mobilized using crutches and wheelchair for 1 month. She returned to PHKL for repeat MRI, X-ray, and surgical management. For past medical history, patient has a hypercholesterolemia. And for past surgical history, she did her LICS 33 years ago. For drug history, she takes statins for her high cholesterol medication. Her premorbid is high function and independent. For social history, her dominant side is right side, and she is a non-smoker and do not drink alcohol. Patient have a sedentary lifestyle. She is married and now live with her family in double story. Her goal is to reduce pain and improve knee movement, return to daily activities independently. On the 1st December 2025, she did an X-ray over her left knee. The result is a grade 3 knee osteoarthritis with reduced medial joint space. She also did an MRI for her left knee. The result is complete ACL tear, horizontal tear of lateral meniscus, marked bone bruise at lateral tibial femoral joint with cartilage defect at the lateral femoral condyle, focal cartilage defect with subchondral cyst at the medial femoral condyle, and mild thinning of the patellar cartilage without defect. For general observation, patient resting on bed. Her body size is mesomorph and has a normal posture. For local observation, patient is with CDD. No deformity noted, bandage and brace intact over left knee and no oozing noted. For palpation, slight warm felt and tender over the left knee. For range of motion, the right limb achieved AFROM with knee flexion 0 to 135 degree. For the left limb, the knee flexion is 0 to 30 degree due to end range pain, and the rest is AFROM. For MMT, the right lower limb achieved overall 5 over 5. For left lower limb, the hip and knee achieved 2 over 5 and ankle achieved 3 over 5. The left side hamstring MMT is deferred due to pain-limited knee flexion. For back mobility, patient require minimal assist. Followed by analysis for the assessment. Pain and tender over left knee due to post-op inflammatory response. Limited ROM on left knee flex due to pain inhibition. Reduced muscle power of left lower limb due to pain inhibition and reduced muscle activation. Reduced mobility due to pain. For short-term goal, we want to reduce knee pain from pain score 6 to 3 out of 10 and below within 3 days. And increase ROM of left knee flex from 0 to 30 degree to 0 to 80 degree within 2 weeks. To increase muscle strength of left lower limb from 2 over 5 to 3 over 5 within 2 weeks. And independent impact mobility within 2 days. And last, ambulate with crutches under supervision within 5 days. For long-term goal, we want to increase the range of motion of the left knee, same with the right knee, which is 135 degree within 2 months. And increase the muscle power of left lower limb, same with the right lower limb, which is 5 over 5 within 2 months. And lastly, ambulate independently and safely within 3 months. Continue with the treatment. First is pain management. Cryo is applied over the left knee for 20 minutes. Next is the ROM exercises, CPM 30 degree over the left knee for 20 minutes. Ankle pump 10 reps, SQE and SLR 10 reps, hip ABD and ADD 10 reps, and then is the back mobility exercises, supine lying to rolling and then sit at the edge of the bed, and then is the ambulate in room partial weight bearing with elbow crutches. For patient education, perform the prescribed exercise for 3 times per day, safe mobilization with assistance, and then we also teach patient how to fit brace and wear it all the time. For the evaluation, patient able to walk with elbow crutches, and the pain score is 6 out of 10 at the beginning, but then it reduced to 4 out of 10 after a few steps. Patient is cooperative and tolerated to all the exercises. For review, we plan to reassess the pain scale, ROM, MMT, and gait, and continue the ROM and strengthening exercises, as well as ambulation for 1 round walk. Moving on to the follow-up, the second visit is in OPD, post-op 2 weeks on 15 December 2025. For subjective assessment, patient complained pain at her left knee when moving the leg, and the left knee is limited bending. The pain score is 4 out of 10 when the left knee flexed over 65 degree, and no pain at rest. Patient goal is to improve the knee movement as soon as possible and return to daily activities independently without walking aid. So for objective assessment, patient came into OPD independently with elbow crutches. And the gait pattern is more weight bearing on the right lower limb. For the local observation, patient wear compression socks on her left leg, bandage intact over the left knee, and then there's a mild swelling and mild redness over the left knee. No oozing over the incision sites. And for palpation, slightly warm is felt over the left knee and tender over the left knee. For the swelling measurement, the left knee circumference is 35.8 cm, while the right knee is 35 cm, which indicate a mild swelling over the left knee with difference of 0.8 cm compared to the right side. The left patellar mobility is slightly hypomobile in the medial and inferior directions with mild pain, while for the right patellar mobility is normal and symmetrical in all directions. Patient range of motion for the left knee flexion has improved. For AROM, patient able to flex from 0 to 75 degree. For PROM is 0 to 85 degree. The MMT for left lower limb has improved. For the hip and knee muscle power has increased to 3 over 5. For the ankle has increased to 4 over 5. The hamstring MMT is still deferred due to the pain-limited knee flexion. For back mobility, patient able to do it independently. Followed by the analysis, mild swelling and redness on left knee, pain and tender over the left knee due to post-op inflammatory response. Slight medial and inferior hypomobility of the left patella due to post-op pain, swelling, and quadriceps inhibition. Limited ROM on left knee flex due to pain inhibition and swelling. Reduced muscle power of left lower limb due to pain inhibition and reduced muscle activation. Increased weight bearing on right lower limb during gait due to avoidance of loading the left lower limb and fear of pain. For the short-term goal, we want to reduce the knee pain from pain score 4 to 1 out of 10 and below within 3 days. Increase ROM of the left knee flex from 0 to 75 degree to 0 to 90 degree within 2 weeks. Increase the muscle strength of left lower limb from 3 to 4 out of 5 within 2 weeks, and ambulate with crutches independently and safely indoor and outdoor within 1 week. For long-term goal, we want to increase the ROM of left knee, same with the right knee, within 2 months, and increase the muscle strength of the left lower limb to 5/5 within 2 months. Ambulate independently and safely within 3 months. Continue with the treatment. ROM exercises and strengthening exercises. Heel slide on gym ball for 10 reps and 3 sets. SQE plus SLR with NMES for 10 minutes. Hip abduction in supine lying for 10 reps and 3 sets. Followed by her machine. Leg press 5 kg for 30 reps. Hip abduction 8 kg for 30 reps. And hip abduction 9 kg for 30 reps. And then is the pain management. Cryo over the left knee for 20 minutes. And the passive range of motion exercise. CPM 85 degree over the left knee for 20 minutes. Lastly is the patient education. Encourage patient to perform the prescribed exercises for 3 times per day and apply cold pack for 15 minutes if there is a swelling. For the evaluation, patient is cooperative and tolerated to all the exercises, and there is a slight improvement of active left knee flexion ROM from 75 degree to 85 degree after the exercises. Review. We want to reassess the knee swelling, pain scale, ROM, MMT, and the gait, and continue the ROM and strengthening exercises as well as a weight bearing training.
And now I am presenting a 6-week post-operative follow-up. Subjectively, the patient reports no pain but described a sensation of tightness during knee flexion and extension. She arrived using a single elbow crutch on her right, despite demonstrating a normal symmetrical gait pattern on level ground. There was a mild swelling, redness, and slight warmth over the left knee, which are typical signs of a lingering inflammatory response at this stage. Quantifying the swelling, the left knee circumference is 35.4 cm, a 0.4 cm difference compared to the right, while patellar mobility remains normal and symmetrical in all directions without pain. Her active knee flexion has improved to 95 degrees, while passive flexion reached 102 degrees. Most importantly, she has maintained full knee extension at 0 degree. Generalized reduction in muscle power, which graded at 4 out of 5, is attributed to reduced physical activity post-surgery. For balance assessment, a slight wobble was observed after 8 seconds during single leg stance on left. She compensated using an anchor strategy to maintain her center of gravity. Analysis links the mild swelling and redness to the ongoing inflammatory response, limited range of motion due to joint stiffness, and reduced muscle power due to reduced activity. Short-term goals are to reduce this swelling within 2 days and improve active knee flexion to 105 degrees within the week, together with improved muscle strength, and aim toward independent ambulation without crutches within 2 weeks. The intervention plan focuses on swelling management, range of motion, and strengthening. We are utilizing half-circle cycling, heel slides on a gym ball, and single leg stance, hold for 30 seconds to address stability. We have also included stepping over cones to mimic the knee flexion needed during a functional gait cycle. Cryotherapy is applied post-exercise to manage the inflammatory response. For evaluation, patients show an immediate improvement in active knee flexion, increasing from 95 degree to 100 degree. She tolerated all exercises well with no pain. Moving forward, we will reassess all metrics and introduce the STAR excursion balance test to provide a more dynamic challenge to her neuromuscular control. That's all from our group. Thank you.